Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by Carium, the telehealth platform enabling healthcare's digital transformation, helping you care for people within the fabric of their daily lives. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Abboud Chaballout, co-founder at Diagnoss. Welcome, Abboud.
Hi, Matt. Thanks for having me.
So, Abboud, what I always like to do before getting into the main part of the discussion is to allow my guests to provide a little bit more of an introduction in terms of who they are and what they do. So the floor is yours.
Sure. I am the founder and CEO of Diagnoss, which is an AI company focused on enhancing EHR productivity for providers.
And what first got you into the healthcare industry?
From an early age, I always thought and worked towards going to medical school. But after college, I ended up getting a Fulbright scholarship, which led me to Amman, Jordan, where I did telemedicine research. And when I came back to the US, I ended up concluding that the impact that I wanted to have on the world would better be served either by going to law school or through starting my own business. So I ended up doing both. I ended up going to law school and then taking sabbatical from law school to start a few healthcare businesses.
Kind of intrigued, what particular aspects of telehealth were you researching during your scholarship year?
So this was 2008, and in 2008, there was a lot of talk about telemedicine, similar to how there's a lot of talk about artificial intelligence today. And at the time, the questions were, will patients accept being treated through video? Is it even possible for doctors to do this? And I right before I went to Amman, Jordan, I had the honor of doing an internship at the Center for Connected Health in Boston at Partners Healthcare, and that's where I learned a lot. I learned basically what I needed to know before my Fulbright, and the scope of what I was looking at is how certain countries can utilize telemedicine and export their human capital or their medical human capital virtually to other countries that didn't have it. And at the time in the Middle East, Amman was known for having some of the best doctors. And there were other countries in the region that were known for not having the best doctors, and that was kind of what I was looking at is to what extent can that technology be used for that purpose.
That's very interesting. As you said, if you're talking, I think you said in the 2008 time frame, I guess maybe saying early in the discussion is probably not accurate, because I know telehealth and the various iterations of it have been around for a very long time. But it kind of sounds like some of the concepts you're studying or researching have now kind of been able to play out and start to really show their benefit over the past year plus.
Yeah, absolutely. And it's been cool to see that. Now, I wasn't really involved in telemedicine after my Fulbright. I ended up going on different paths, but in just looking at it retrospectively, it is interesting to see kind of how long and what it takes for certain technologies to really become ubiquitous in our healthcare industry. I mean, really, like, if you can argue that it's not until the pandemic that telehealth became the norm, right? Even before a pandemic, people were doing telemedicine, but people still defaulted to calling the doctor and trying to go to a physical clinic. Whereas, in 2020, basically the default was you're going to see your doctor by video or just talk to them on the phone. I mean, with my two kids, we were just talking to our pediatrician through the phone. And that was the extent of the care that my my newborn and my at the time my 14-month-old were getting.
No, I think that's definitely right. And it's, as you said, knowing that you haven't necessarily been focusing on it since the research with, it sounds like a lot of intensity, would like to kind of pivot to what you said, which is an interesting combination of wanting to make a difference by either pursuing law school or doing a startup. And as you said, you've done both, which I feel like is not necessarily a typical combination. So we want to give a little bit more detail and kind of what both of those paths have meant to you.
Yeah, it's it's interesting. I feel life has taken me in various directions, not always directly where I want to be, but has helped me get to where I hope to go to in the future. So for me, coming back from Amman, law school was the clear winner in terms of what I was going to do between starting a business and or doing law school. So I did that. But interestingly enough, in the middle of law school, I ended up having an opportunity to start my own business, and it was both healthcare and legal related. So I ended up finding this really interesting niche, litigating unpaid B2B medical debt in California. And basically what that meant is we were actually not just litigation, but in investing. So we were investing in and litigating unpaid B2B medical bills. And what that meant is that we would get these insurance bills that were unpaid by insurance companies to providers, and we would offer those providers liquidity on those bills, and then we would litigate the carriers that owed the balance. And I learned a lot about how money flows in our healthcare industry. And more importantly, I learned a lot about the pain points that providers face in operating their medical businesses and medical establishments on a day-to-day basis. And that's where I also learned a lot about medical coding and medical billing, which is in many ways the lifeblood of these establishments.
In your reference there to the medical billing and coding as a lifeblood is, really, kind of keys in on an important point, and one that I suspect people outside of running a healthcare organization might not realize. So can you provide a little bit of background in terms of what's actually meant by medical billing and coding?
Sure. On a conceptual level, the way I look at coding is that it's a translation. It's a language that we use to translate what doctors and providers do to treat patients, and what they see as the patient's ailment. And that language is then offered to an insurance company or to a government or to the establishment in which the provider operates in, to do a variety of things. I mean, when you send these codes to an insurance company, usually that's intended to trigger a reimbursement of sorts. But these codes are also looked at by governments and larger health systems and organizations to essentially manage population health. That's how these institutions essentially know what's happening on the ground. And you can imagine that these codes are also used for a variety of other things. So insurance companies use these codes to run actuarial models to figure out how much in reimbursements should be made in the first place. So there's a lot that happens with these codes, but the way I see it is it's a way to translate what's happening onto the ground into a language that multiple parties can actually make use of.
And what are the challenges with kind of accurately making that translation?
Well, There are a number of challenges. The first I'll point out is that coding typically isn't done by one party. This translation isn't typically done by only one party. There's usually multiple parties involved, and those parties are usually the providers and the medical coders that follow the providers. And that in and of itself is an interesting situation, because you have a provider who is trying to do this translation, but nowhere in their clinical training were they trained on this translation process. So they don't take medical coding classes. And then on the other hand, the medical coders who are typically certified in this task of medical coding are not clinically trained, but they're expected to read doctor's notes, no matter how complicated they are, and translate them into these codes. And this dance between the two parties often creates errors that then have to be fixed after the fact. Another issue is that there are a lot of codes. With ICD-10, there are almost 100,000 codes. And obviously, if you're a specialist, you're not dealing with 100,000 codes, but there are still a lot of codes to work with, even within a specific specialty. So the task of coding typically is you need to pick the most specific code for the issue at hand, and oftentimes that means browsing through a few dozen codes just to get to the right one. So you can have a few dozen diabetes codes, probably with diabetes, probably even more than a few dozen, to get to the exact diabetes code that applies to this specific patient encounter. So the dealing with specificity is another big problem. But there's also a third problem, which is the translation is really only as good as the documentation. So in other words, correct coding and exhaustive and comprehensive documentation go hand in hand. And oftentimes, in order to improve an organization's performance when it comes to coding, you have to improve its performance when it comes to the documentation that is left by its clinicians.
No, and I think there is, kind of as you said, so many different layers there where an issue could arise. And I'd actually want to digress on one point. You kind of gave the example of ICD-10 and the multitude of codes there, but kind of how many different code systems are actually utilized, and are you using different code sets depending on, I think as you were saying, you could be potentially dealing with a private health insurance company or the government. And kind of part of the basis for that question is, I probably a few years ago, people got used to hearing about ICD-10 when it converted over to that system. But you also hear about CPT codes and HCPCS codes. So kind of what are the differences between all those?
Yes, good question. So generally speaking, I want to say there's three main code sets. I mean, there are more, but these are the ones that people typically work with. So ICD is an international system, and it's actually created by the World Health Organization. Now, in the US, we have a slightly modified version of ICD, and that is managed by CMS. ICD essentially means diagnosis. So the ICD-10 code set is the code set that you use to indicate a diagnosis of a patient. Now, you mentioned the letters CPT. CPT codes are created by the American Medical Association, and those codes are used to describe procedures, i.e. the service that was rendered by the provider to the patient. So ICD, diagnosis, what's wrong with the patient. CPT, procedure, what the provider did for the patient. And then you have HCPCS. And these codes typically describe something tangible like medicine or DME, durable medical equipment. So it's a physical object that you're providing for a patient. And I would categorize that more in the procedure category. And the best way to think about the dynamic between CPT, HCPCS, and diagnosis is CPT and HCPCS are what you get reimbursed for as a provider, and ICD, i.e. diagnoses, are how you justify that reimbursement, how you justify what you did for that patient, if that makes sense. And oftentimes I see, when people talk about medical necessity or indicating medical necessity on a bill, what they're referring to is that it is a comprehensive and an exhaustive list of the diagnoses of the patient that justified that procedure to begin with.
That breakdown is actually really helpful, and I don't know. I don't think I've heard it kind of explained in that way before, which honestly makes it a lot easier to understand and to kind of connect the dots. But for those of you just joining, I'm talking with Abboud, co-founder of Diagnoss. We're talking about medical billing and coding, and kind of jumping off of the description you just gave of kind of the flow across those different code sets, and kind of what you were saying earlier about all the layers of complexity. How can this process be made easier? Because I think you made a great point, which is physicians aren't being trained about this in medical school or residency, nor do I suspect that they want to be. So how do we? How would it be possible to kind of make the whole billing and coding, process something that is less of a pain point?
This is something that we think about every day at Diagnoss, and I'm debating between giving you a short answer versus a long answer. And I think I'm just going to go with the long answer because I think it's more interesting. The way I look at coding is a spectrum of job completion. Okay, with the left side of the spectrum being job incomplete, meaning coding incomplete, to the right side of the spectrum being job 100% complete. In earlier in the discussion, we were talking about how there's different parties involved in the coding process, and they all play a role in completing the job of coding. So in order to make coding easier and more efficient, my first point here would be is that I don't think there's one way to make it more efficient. I would argue that there would need to be multiple approaches to making it more efficient, because you have to cater to each party and you have to be able to cater to each part of that spectrum. Generally speaking, and I want to underscore that each clinic, each hospital has different workflows. Generally speaking, you have a provider who's tasked with simply picking codes. They're not accountable for those codes being correct because the expectation is the code is not going to go straight to bill. But they pick the codes, and then generally speaking, they're going to be followed by a medical coder who's going to look at those codes and then look at the patient encounter, meaning the doctor's notes, to either validate that those codes are correct or add additional codes or remove certain codes or make certain codes more specific so that it's more suitable for billing. So when you break it down, that's essentially two different jobs, right? So you have a doctor who's tasked with simply picking a code. That's one job. And then you have a coder who's responsible for getting the code right. Completely different job with completely different accountability levels. So at Diagnoss, what we're focused on is catering to the doctor and helping them with the task of picking codes, and helping them to do it more quickly and more accurately, so that parties and players downstream can focus on bigger picture items, and hopefully reduce the back and forth that usually happens between coders trying to verify things that doctors verify codes that doctors are picking, and the documentation that's supporting it. So in terms of making it more efficient, it would require building technology for the multiple parties that are involved, and also building multiple technologies for the different tasks that are required to actually complete the coding job.
In kind of the differing roles that you were just describing, in terms of the physician maybe in picking an initial code that seems to reflect what was actually rendered, and then that being assessed in what's likely much greater detail by hopefully an actually trained coder, because I think you mentioned earlier, there's definitely certifications and for coders, because it is such a complex area. But kind of that interaction is very unique, and because my understanding is that when the bill is actually sent out the door, you essentially have an attestation from the physician that it's accurate, even though I think, as you were saying, they might not really understand how to do it. What constitutes a really accurate code to assign to the service or procedure that was rendered.
Yeah, and it's because of this attestation, what you end up having are a lot of conversations between coders and providers. So coders are not legally speaking, they can't just put diagnoses and put procedures onto the bill and just send it to an insurance carrier. It has to be signed off by the provider. But what that creates is this discussion between them, much of which can be eliminated if the provider is able to pick the more correct codes from the beginning. And the reason that's important is because these conversations take time, and more importantly, they delay the billing process, because rather than billing it the next day, by the time the provider actually reads the coder's note or answers the coder's question, a week may have gone by, and the bill is just sitting there. And from a business perspective, that's hitting the clinic's cash flow. So there is this interesting dynamic, which makes things even more confusing, and more inefficient. And our thesis is that by being there with the provider and helping them pick better codes more quickly and more accurately, it'll introduce efficiencies downstream as well.
No, and I think that intuitively makes sense, because correct me if I'm wrong, but it sounds like you're kind of the suggestion is to fit that guidance and suggestion into the workflow that the physician is already following, so that it's not necessarily an extra step so much as maybe a refinement of what's already being done.
Correct. The way we think about our technology is a mixture between Grammarly and autocomplete. So we've basically built this assistant, and it's a sidebar, and it integrates with the provider's EHR in a uniform manner, which basically means that they don't have to open a second piece of software. It's there in the same window as their EHR. And what it does is it reads their notes, and it looks at the metadata surrounding that patient encounter, and it'll begin to make suggestions as to what codes would apply. Similar how Grammarly will read your emails and then give you grammar suggestions. And it'll autocomplete based on how you interact with it, with more code suggestions. The concept is basically to deliver relevant suggestions, relevant and targeted suggestions to providers in a way that's not distracting, and in a way that actually significantly saves them time. To further elaborate on that point, it's very important to understand that when it comes to coding, you have medical coders in-house, you have outsourced medical coders that do the work, and then you have technology that supports both of those players, so both the in-house coders and the outsourced coders. But what you don't really have today is technology supporting the provider. At best, what a provider has and what they typically rely on is a search bar that is in their EHR. And to kind of paint this picture, as a provider, you'll spend, let's say on average, 15 minutes putting together a patient note. And then at the end of it, you have to go and select these diagnosis codes and include them in the patient's note or in their chart. And what you have to do is you have to go to a very specific screen within an EHR. You have to find the relevant search bar, and then you start typing out the diagnosis that you want. So if it's some sort of asthma code, you'll type AST, and then you'll get a list of search results, and you have to scroll through them, maybe read a bunch of them until you find the one that you want. And then you have to rinse and repeat that for the total number of diagnoses that the patient has. So if you're a primary care provider, let's say the patient, let's say you're going to document 10 different diagnoses that you're managing for the patient at any given time. I mean, you have to basically go through that search, and scroll process 10 times. And what we're trying to do is say, hey, you've already written the note. We already know we already are looking at the metadata surrounding the note. Why don't we just give you the relevant codes up front without forcing you to go search for them?
No, and that definitely makes sense. And it's, I think kind of implicit in what you're describing is it's trying to ease the burdens that are on the clinicians and the physicians as they're going through this, as you said, already multi-step process. And it's, definitely seems designed to have a way for technology to actually be providing a benefit. And, actually, believe it or not, we're already out of time. So that's actually, I think a great thought to leave on, because as you're saying, it's a way to try and relieve and enhance the workflows for physicians and other clinicians. But I do want to thank my guest, Abboud Chaballout, for a great conversation today.
Absolutely, Matt. Glad to be on your show.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.